Hello everyone, I am about to be joined live by Dr. Tumi from the Advanced Fertility Center of Chicago, a Prelude Network clinic, to discuss IVF success rates for specific situations. So we're very excited to be answering some great questions that have come in from you guys, and it will be a very informative conversation about IVF success rates for many different scenarios. Hello to those who are joining. Nice to see you today. I'm about to be joined by Dr. Tumi, who is joining me from the Advanced Fertility Center of Chicago. Just going to check she's here now and we can get started. Hi everyone. Nice to see you today. I am just waiting for her to join. Have your questions ready about IVF success rates. Anything you want to know, she will be happy to answer. We'll be talking about success rates after a D&C to over age 40 with a mini cycle, with PCOS and much more. So let me see where she is and we will begin. Hi to those who are joining. Nice to see you today. Okay, we should be ready to get started. Hopefully tech will be on our side today.
Hello.
Hello, Dr. Tumi. Lovely to connect with you and go live with you today.
Likewise, it's good to meet you in person. How are you?
I'm very well, thanks. How are you?
Oh, thank
Good.
you. Very excited for this talk.
Absolutely. I've just given a brief introduction to what we're going to be discussing today around IVF success rates for many different types of situations. So before we begin, if you could please introduce yourself, tell us a little bit about your background, the Advanced Fertility Center of Chicago, and then we can get started on this fantastic topic.
Yes, of course, I'd love to. So my name is Tumi Kuyaro. I'm one of the newest physicians at Advanced Fertility Center in Chicago. We are one of the Prelude Network clinics. We have many, or I should say we have about 4 offices here in the Chicago and Chicago area. Excitingly, from next month, we're also opening up our second IVF lab in the Chicago downtown area as well, which is where I'd be primarily based as well.
Okay, amazing. And I have invited people to ask questions as we're talking. We've had some great questions ahead of discussing IVF success rates today. I'm sure you get it every day from patients. So let's go through it.
I love having these conversations.
Absolutely.
So looking forward to it.
Yeah. Absolutely. So first of all, I would love to understand, what should patients really focus on when looking at numbers? Absolutely. Because I know things can be misleading online.
Absolutely. So the number one thing, or I would say the first thing in terms of numbers that any patient or any couple should be thinking about when trying to conceive is, one, the age of the female partner in that couple, because this really determines, one, whether or not they meet criteria for the diagnosis of infertility, and if and when they should seek help. And two, age also then determines the success rates for the different types of treatments they may be offered. And then in terms of success rates, there's kind of 2 numbers that we should hone in on, which are your live birth rate per egg retrieval and live birth rate per embryo transfer. But it's very important to be looking at this in the context of age. You want to be comparing, first of all, any clinic that you go to, you want to look at what their success rates are as compared to the national average, but honing in on age-specific data. It's like comparing ages, apples to oranges, if you're looking at success rates, but not looking at success rates specific to the age group that you're in.
That makes complete sense. Do you find you often have patients coming in saying, well, I had a friend who got this, this result, so what does this mean for me? And, obviously might be concerned about age or at what point they're doing things in their fertility journey?
As always, the most important thing is really age, because that determines, and I'm sure we'll get into it as we speak more, it determines both egg quality and egg quantity. However, there are also many other things that factors the diagnosis, the reason why they have infertility, that could affect success rates. So I always caution when comparing one person's story versus the other, because this whole issue is very nuanced and very specific and should be individualized and cannot always be compared across individuals.
Of course, that makes Makes sense. And if anyone has any questions for Dr. Toomey as we're discussing, please do feel free to drop them in the comment box. You can also head to our link in bio to find out more about the Prelude Network and to speak to the team directly for personalised treatment, care and plan. What would you say are the biggest challenges patients commonly see with IVF success over the age of 40, and what options are out there to help people improve the chances of success?
I love that question, but I'm just going to take
Yeah.
it back and talk about how fertility works naturally. So, as women, we're born with all the eggs we're ever going to get. We don't make any more. Once you start the process of puberty and you start having periods, every month a bunch of those eggs that are contained within the follicles and the ovaries start to develop. The Those follicles start to develop. However, only one of those follicles becomes big enough in order to release the egg that it contains when you ovulate. We call that follicle the dominant follicle. However, the rest of the follicles that started to develop but did not become the dominant follicle, they actually degenerate and they die. And this is why, as we get older, the number of eggs that we have starts to decrease. And so, but in addition to decrease in quantity of eggs, the other issue that we're dealing with is also decreased quality of eggs. And by quality, I mean the genetic material or the number of chromosomes that the eggs contain. The eggs start to, as we get older, the eggs start to accumulate a lot of genetic errors, meaning that they just have the wrong number of chromosomes and the information sometimes those chromosomes contain don't make sense. And so as that is like, those are two issues that are difficult to circumvent.
Yeah.
And so as we get older, we're dealing with both decreased quality and decreased quantity. And this is why we see that as women get older, as we get older, the live birth rate starts to decrease, whereas the rate of miscarriages increases. And so the one main thing, or the big thing in terms of any couple who's, let's say, in their late 30s or in their early 40s, looking to conceive or contemplating becoming pregnant, is early intervention. Mm-hmm. If this is something that has crossed your mind, you're not sure of what your options are, you're not sure of what your fertility is, I would urge anyone in such a situation, if feasible, to be seen by a fertility expert, an REI, so that you can go over do the various testings and go over what options are appropriate and feasible for your specific specific clinical situation. But then there are also other things to be considered as well. Like I said, the age and age, which affects both egg quality and quantity, and not things that are easily circumvented, but other things that are within our control that could potentially help success rates are things like lifestyle and health factors. So you want to think about your diet, your nutrition, and generally maintaining a healthy weight, reducing stress where feasible, and then plus or minus some supplements which may or may not help. And then once you're plugged into a fertility clinic, you and your doctor want to be talking about specific protocols that meet your specific clinical situation in order to optimize or maximize your ovarian stimulation and potential yields. And then in some cases where there's only so much that can be done, sometimes that conversation may need to be about potentially using donor eggs.
Yeah. Do you find it's a common question that patients ask you when they're about to start a cycle? You're doing that first consultation. What does my success rate look like based on my situation?
Absolutely. So, the number one predictor is always age. Like, no matter what diagnosis is, number one predictor is always age, because the one thing that there's only so much we can do about is egg quality and egg quantity. Having said that, like I said, those things that we talk about, like lifestyle, those modifiable factors may to some extent affect those success rates. And finally, I always say sometimes we just don't know until you actually undergo the cycle. And, especially I always tell my patients, realistically, and our patients over the age of 40, in order to get to that one, genetically normal embryo, that may require multiple IVF cycles. And sometimes we don't know until you undergo that first cycle what the optimal protocol is for you and what your response to the medications might be.
That's a very good thing that you've just brought up, because how many cycles would you say might be average for people to have in order to hopefully have success? Because I presume you will learn a lot from that initial or even the first couple potentially of cycles,
Right.
based on protocol, how people are responding, etc.
Absolutely. You know, like I wouldn't say there is necessarily an average number, but I would say anyone over the age of 40 should expect to have at least to be able to get to an embryo that might result in a live birth, at least, at the very least, 2 cycles.
That's really, really helpful to know.
Mm-hmm.
If anyone has any questions for Dr. Tumi, please ask, because this is an amazing opportunity to have expert knowledge live. I also wanted to ask you, how do success rates change for mini IVF compared to conventional IVF?
Mm-hmm.
So, who might be a good candidate for mini IVF? Would they come to you saying, "This is me. Is this me?" Do you suggest it? How does that work?
I'm happy to like talk about mini IVF. This is a conversation I'm happy to talk about, not because I have like any specific
Yeah.
answers, but I think it's a conversation worth having. So what is mini IVF? Mini IVF is mini stimulation IVF, and it's a type of IVF that uses lower doses of fertility medications when you compare it to what we'll call conventional IVF. And the typical patients who might be, or who you might see undergoing such a cycle, are patients who might be older, or patients who have what we call diminished ovarian reserve, so have a low egg count. The evidence for mini IVF protocols, especially for women over the age of 40, is, I would say, it's mixed or inconclusive at best. The most robust studies that we have today still suggest that traditional high dose ovarian stimulation protocols are still what provide the best outcomes in most cases. The proposed benefits of mini IVF include potentially better egg quality, and the rationale here is that in certain patients, lower doses of the medications we use to stimulate the ovaries might actually lead to better egg quality. The other thought is that because we're using lower doses of those medications, it might mimic what happens naturally, and that may be better for both the quality and the maturation of the eggs. The other more practical implications of this is that by using lower doses, it reduces you need less medication, and so it reduces the cost of IVF, a potential IVF cycle. And also by using lower medications, you also reduce the risk of things like hyperstimulation of syndrome, where the ovaries become hyperstimulated. Having said that, the typical patient population in which we do see mini IVF are not also the patients that you might expect to become hyperstimulated. So that's really something to bear in mind. It's also important to really talk about the limitations of mini IVF. So the goal of any ovarian stimulation cycle or protocol is to end up with at least one genetically normal embryo that could result in a live birth. What one has to bear in mind is that by doing a mini stimulation or using lower doses of medications, you might end up with a lower egg number, which reduces the chances, or potentially reduces the chance of you ending up with a genetically normal egg, and hence a genetically normal embryo, and hence a live birth. And so because for that reason, you may need to do multiple cycles, which could then nullify any cost benefits in the end. So those are really the two things to bear in mind. You know, we do these things on an individualized basis, and having said this, you know, we have what studies show and we bear in mind, but it's always these things are important conversations between the patient and the provider, doing things on an individualized basis and making sure that decisions are made based off of informed, you know, everyone involved in the care is making informed decisions about what's best for that particular patient.
Absolutely. And I presume you will see complex cases as well, where people may be looking to switch clinics potentially and look for a second opinion.
Yes, well, most definitely. For that reason, which we had mentioned that, you know, people, especially over the age of 40, may need multiple cycles. And even in cases in younger patients, may still need multiple cycles.
Yeah.
And so sometimes, you know, people get discouraged after not having the outcome that they may want in one prior cycle, and they just want to see if something could potentially be offered and done differently in another clinic or in another environment.
Absolutely.
Yeah.
We've just had a private question come in, so please do send questions in, which was actually going to be my next question to you anyway.
Yeah.
It's about PCOS and the challenges
Mm-hmm.
that presents in IVF. How does treatment adapt to improve success rates for your patients who may be struggling with PCOS?
Before I go into PCOS and IVF, I just want to spend some time really quickly talking about what PCOS
Yes,
is.
please.
So PCOS stands for polycystic ovarian syndrome, and in order to be diagnosed as having PCOS, you need to meet 2 out of 3 criteria. What are these criteria? The first criteria is having signs of what we call hyperandrogenism, either on your blood work or your physical exam. Androgens are hormones in that testosterone family. So they're responsible for things like having acne or having hair in a male pattern distribution. So if you're someone who has acne or male pattern distribution hair, PCOS might be a diagnosis to be thinking about in addition to some of these other criteria that I would mention. So the second criteria is having period irregularities. So if you're someone who has irregular periods in addition to having signs of hyperandrogenism, this is a PCOS again, should be a diagnosis that you should be thinking perhaps maybe I want to discuss with my doctor. And last but not the least is having polycystic ovaries. And this is something that we find on ultrasound. Now, although the name polycystic is somewhat of a misnomer because it doesn't mean having lots of cysts on your ovaries. What it means is that you have tons of follicles, and those are what is actually the polycystic. Those are the polycystic nature. It's not cysts, it's actually just having follicles, which contain the eggs. So I like to think of PCOS almost like a double-edged sword. Because your ovaries are polycystic in nature, it means that potentially you might actually have a higher number of follicles and thus a higher number of eggs than someone within your age group. And so for that reason, you may be at a slight advantage. However, because what is underpinning the PCOS is a miscommunication or a lack of proper communication between the brain and the ovaries, those eggs and those follicles are not functioning the way that they should.
Yeah.
So when it then comes to treatment, there are 2 kind of arms of treatment. What we want to try and do is figure out if we can get those eggs to function the way they should, and also improve the microenvironment within those where those eggs are contained, because that could affect egg quality. And so whatever form of treatment we offer for someone who has PCOS, so either IVF or IUI, one of the main things that we also want to be thinking about is improving that egg quality in certain cases. And so one of the things that could help with that are, lifestyle, again, and I'll keep mentioning this, I'll mention this over several times, is, diet, your nutrition, and in some cases, some medications and supplements. So medications like metformin, which could help improve that quality of that microenvironment within which the eggs. Now, when it comes to treatment, and I'll speak here specifically of IVF, the one thing that you really want to bear in mind is with patients who have PCOS, because they have this higher than average number of eggs, they're at risk of being hyperstimulated. And so the way we manage their cycles is we use specific types of medications and we use very specific doses in order to reduce that risk. And then, like I said, even undergoing a cycle, we're also making sure that we're doing things that would help us optimize the yield and also the quality of the eggs. Unfortunately, we don't have any way of testing egg quality. The only sort of way we can extrapolate what we think egg qualities is based off of the age of a female patient, but we don't have any way of really knowing what the quality of eggs are that we are retrieving. We can only really make those assumptions based off of embryo development and what the embryos become.
Yeah. Really, really insightful. Thank you so much. I'm sure that's answered the person's question, so thank you. And I'll actually ask you that question in relation to endometriosis and IVF success as well. Would you mind explaining a little bit more about that as well, please?
Right. So endometriosis has it's a very complex gynecological condition, and it's caused by having basically tissue that should only be found within the lining of the uterus, but outside of the uterus. And so you have these implants, uterine lining implants, scattered all over the pelvis. And what it does is that it causes an environment where there's a lot of inflammation. And for various reasons, that inflammation then reduces the chances of pregnancy. If that inflammation, or if that uterine tissue is also found on the ovaries, it might result in something called endometriomas, which are very specific cysts that we find on the ovaries that are related to endometriosis. And in cases with endometriomas, it could affect both egg quality and egg quantity because of that inflammatory environment that that is as a result of as a result of the inflammation caused by the endometriosis.
Thank you for explaining. That's really, really helpful. For anyone joining, we are discussing IVF success rates and factors that can kind of change that for specific situations. And if you have any questions for Dr. Tumi as we're talking, please feel free to ask. We've also linked up in the bio the Prelude Network so you can find out more about personalised care for your needs. In terms of unexplained infertility, this is obviously a challenging one for people to not necessarily know why they're not able to conceive and need assisted reproduction. How do IVF success rates compare to other situations with unexplained infertility?
So just to give a quick background, unexplained infertility, as the name suggests, is basically infertility where we're not able to find a reason for. So when a couple comes in for a basic workup for infertility, some of the things that we do to test, the fallopian tubes to see if that's the cause of the infertility, to look at the uterine environment. We also look at the ovaries, and then we test the sperm. If all of our tests reveal that there aren't any issues in any of these factors I've just mentioned, then we unfortunately use that term unexplained infertility because we can't pinpoint what the cause of infertility is. Having said that, it doesn't mean that there's a reason. There isn't a reason. It just means that right now the technology that we have is not able to identify or elucidate what that form of what that cause of the infertility is. And we know that it's actually pretty common. About a third of couples who present with infertility actually will have unexplained infertility. We do have some theories about what may be causing this, but unfortunately we don't have any real ways of testing it. One of the thoughts is that there are probably a subset of patients who have endometriosis but don't present in the typical way endometriosis usually presents, like very painful periods, or they have vague symptoms that don't shout or scream endometriosis, and the only way then we're able to really suspect is that they then have down the line may have problems conceiving. Having said that, just because we can't identify or class them as being, having infertility due to the tubes or the uterus or the sperm, it doesn't mean that the treatment options are not the same. So as with most forms of infertility, two main forms of treatment are either medicated IUI cycles or IVF. And success rates, and there's no evidence to suggest that patients with unexplained infertility have different success rates. As with any other cause of infertility, the biggest predictor is actually the age of the female partner, or the partner seeking to undergo whatever form of fertility treatment.
Really, really useful to know. Thank you so much. Someone just saying that they are in the IVF process. We hope this works for you as well. A question, if you have time, what would be the reason why an embryo may not thaw?
So when I'm not sure what this person means by thaw, but I'm going to assume they mean not survive the thaw.
Yeah.
Yeah. So there are many reasons. Unfortunately, only a handful we can really tease out, but some of the reasons why may be the quality of the embryo itself, which often is reflective of the quality of the eggs that made the embryo. To a lesser extent, the quality of the sperm does matter, although we know that the egg quality weighs more, most likely, than the sperm. And then there are other things that could be the technique that was used in both freezing and also thawing those embryos, and just also the environment of the lab within which the embryos were thawed and were frozen and also thawed, that could play a part as well. Like I said, unfortunately, we don't have any way for sure of knowing what the quality of the eggs are. The only way we can know or make presumptions on the quality of the egg is to test the embryos that were made from that egg and see whether or not they were genetically normal, meaning does that embryo have the full complement of chromosomes that it should have in order to be classed as being a genetically normal embryo.
That's really useful to know. I'm sure that's answered that person's question. We just had another one come in privately. How much sperm is needed for a cycle of IVF?
Right,
Good
that's a
question.
good question. So that's a great question. Not much sperm actually, and that's why IVF is often treatment for issues with, male factor infertility, where there might be an issue with either the quality of the sperm, the numbers of the sperm, or the movement of the sperm, or the shape of the sperm, because we don't need that much sperm to fertilize the egg. One other great part of IVF, we now have a technology called ICSI, which stands for ICSI, which stands for intracytoplasmic sperm injections. And when there are any issues in any of the parameters of the sperm, either with the numbers or the shape or the morphology or the movement of the sperm, what our embryologist can do is to take a single sperm cell and actually inject it into the egg. And so because we can isolate single sperms and actually inject them into the eggs, you don't actually need that much sperm in order to do IVF. Of course, certain thresholds still need to be met, but the great thing about IVF is that you don't need as much sperm as you might need in conceiving spontaneously on your own.
Absolutely. And would you use ICSI with frozen sperm?
Typically, embryologists would prefer to use ICSI when a sperm sample has been frozen.
That's
The other reason, like I said, the other reason we do ICSI is if there are any issues with the sperm, or in cases where certain embryologists might prefer to do ICSI in cases where there is the plan to genetically test those embryos, then embryologists prefer to do ICSI as well.
Okay, that's really useful to know. There's another question around sperm, if you're able or have time to answer, please. What threshold is needed? This person has said, I know IUI, it's 5 mil plus typical. Is that
so
correct?
typically you want at least anywhere between 5 to 10 motile, the total motile count. You want anywhere between 5 to 10. Even so IUI itself, and I would just back up and say IUI is not a very efficient way of becoming pregnant, even in cases where everything is perfect, meaning we can't find any issues with the sperm or the eggs, the egg numbers or the uterus or the tubes. Even in those cases, IUI only offers between a 12 to 18% chance of pregnancy per cycle. Having said that, you don't need perfect sperm to do IUIs. You just need to meet certain thresholds, and that's somewhere between, like I said, between 5 and 10 million total motile count, a TMC of between 5 to 10 million.
Thank you. That's really useful. Going back to endo, someone has just said that endo is so often missed on imaging at basic provider levels. I think this person may have experienced that going to an RE with own skilled techs made a world of difference. So would you advise people, if they think that they may have endometriosis, to come and get checked out?
If you have one of the unfortunate, one of the main, endometriosis is a condition that goes undiagnosed for many years for a variety of reasons. People think that having extremely painful periods are normal. Some cases we may not be able to find a reason, but endometriosis should be on the top of your differential if you're someone who has painful periods. And one of the ways that we diagnose endometriosis is ultrasound. However, like this person has mentioned, it's something that sometimes gets missed. One of the hallmarks of endometriosis on an ultrasound is the presence of those endometriomas I had mentioned earlier, those cysts on the ovaries. However, in many cases, when we don't see those cysts, endometriosis can be missed. However, now we're in an age where ultrasound technology has improved, and now we're begin to pick up signs of endometriosis that are not limited to endometriomas and ultrasounds. People are getting more and more familiar with being able to pick up their signs. So hopefully this should lead to earlier diagnosis. But I guess I will circle back and just say, if you're having painful periods and so far you haven't been able to have a diagnosis, I would speak to your provider, your OBGYN, or your fertility doctor about the potential of endometriosis, because endometriosis is something that could, long-standing endometriosis is something that could result in infertility if it's not diagnosed and detected early enough.
Mm-hmm. Yeah, and there are lots of, well, there are other symptoms people can look for as well, aren't they? Would I be right in saying painful sex as well?
Absolutely, yes. Painful intercourse is one of the hallmarks of endometriosis, and sometimes pain with urine, like bladder spasms. Those, because I had mentioned, endometriosis is having that uterine tissue scattered all over your pelvis, and one of the places that you might feel, you might have those implants, those uterine implants, are on the bladder. So if you're having like spasms when you're urinating, and they haven't been able to find if you complain of such a symptom, they might just do a urine analysis in you and not find a reason on your urine. One of the things they should be perhaps think, if this is something that persists, is potentially endometriosis. And yes, definitely painful sex is one of the big symptoms of endometriosis to look out for.
Thank you for clarifying. I also wanted to ask you, as we all know, sadly miscarriages often happen, and having a D&C, how can that affect IVF success rate? What could be done to improve IVF outcomes?
So a D&C, and it stands for dilation and curettage. So we use an instrument called a dilator to dilate the cervix, which then allows us to pass a curette into the uterus, which we then use to either remove the contents of the uterus or to take a sample of the uterine lining. Now, a D&C in of itself should not affect your IVF success rates if done properly. However, there may be individuals, for one reason or the other, who have had to undergo multiple D&Cs. And in those cases, repeated instrumentation on the uterus could affect the integrity of the lining such that scar tissue starts to build up. We call that Asherman syndrome. And in cases of Asherman syndrome, basically the lining of the uterus is not vascularized properly. The blood supply to the lining is compromised, and that affects then the ability of an embryo to implant successfully into such a lining. And so in cases where it's suspected that there may be issues with the lining due to maybe repeated D&Cs, having a procedure called a hysteroscopy, where we put in a camera into the uterus and looking around just to see exactly what's going on the lining, may give us an idea as to what's going on. Now, if we do identify that a patient may have Asherman syndrome, at the time of the hysteroscopy, what we can also do is use instruments to maybe take down some of that scar tissue. And also then once that scar tissue is taken down, we do things that may help to revascularize the endometrial lining. One of the exciting studies that are coming out now is the use of hyaluronic acid actually to help restore that integrity of the lining as well. And then when it actually comes to a potential embryo transfer cycle, there are different protocols that we can use that can help really optimize building that lining as much as possible. But it's also, some people with thin linings just have thin linings. We may not be able to get to that optimal number, but having said that, many people, even in those cases, are able to, have a successful implantation and successful live births, even with suboptimal linings.
Is that sometimes the case, or could that sometimes be the case after a C-section as well for people with secondary infertility?
Well, it depends on how the C-section was done. Any sort of procedure where the uterine lining has been disrupted in any way, and that could include a C-section, could potentially affect that integrity of the C-section. If after the C-section all the products were not removed, if there were some retained products in the uterus, and that may have required then subsequent procedures in order to remove those products, that could also affect the quality of the lining down the line as well.
Okay.
Yeah.
So with everything we've discussed today, we've been through a lot, and obviously there are so many variables when it comes to success rates for IVF. What would you say are the factors that make the biggest difference in individual IVF success?
Individual IVF success. So beyond the standard protocols, beyond what is what is being done everywhere, the one thing is really the age of the woman in a couple, because that determines both the egg number and the egg quality, which is why early intervention is always going to be best. So like I had mentioned at the start of this talk, if at any point, you're in your mid to late 30s, you know what, if you have any questions about your fertility, regardless of your age, either speak to your OBGYN, or if you have access, speak to your RAI. I think these conversations are very important to have, and ideally the earlier the better. That age, like I said, just to wrap up, age is always the most significant factor. The age of the female partner is always a significant factor, although to a lesser extent the age of the male factor also does play a part. And then something I had also mentioned is lifestyle and health factors. You want to really just try and maintain as much as you can a healthy diet. Eat foods rich in antioxidants, because this could affect your egg quality. Try and maintain a healthy weight, because weights above a certain threshold have been shown to negatively impact both the success of embryos implanted and also increase the rate of miscarriages. You want to try and limit your alcohol intake. You want to try and limit your tobacco intake. Want to avoid things like chronic stress, poor sleep. And then I'm always a bit wary of promoting any supplement over the other, but there are some supplements that have tentatively been shown to potentially improve egg quality, such as CoQ10.
That's really great advice. Really, really appreciate your expertise today, Dr. Tumi. We've had a ton of other questions come in privately, so I would include in questions around egg freezing as well, which is a bit off topic today, but
No,
I would recommend people to head to our link in bio, reach out to your team, and advocate for yourself to get started with getting some personalized care, and really being able to have a conversation about your personalized goals and take it from there. So really appreciate your time today. Thank you everyone for joining and watching back, and we'll be speaking to you very soon.
Thank you so much. Thank you for having me. This was great.
Absolutely. Thanks again. Have a great day. Thanks everyone. Bye-bye. Bye.